pH imbalance can occur for various reasons. The event which leads to pH alteration in the first place is called primary acid-base disturbance. Our body wants to maintain the normal range pH, so it responds to this with a process called compensation. Compensation is body's attempt to bring pH close to normal, to sort of maintain homeostasis. Because compensation is not perfect, it can't correct or overcorrect the abnormal pH. Depending on what the primary disturbance does to the body, compensation can make the disturbed environment a little less acidic or less alkaline, but it can't really correct pH. And based on what I just said, if you ever see a normal pH or an overly corrected pH with abnormal levels of CO2 and bicarbonate, think of mixed or combined disturbance. This is when there is more than one primary acid-base disturbance going on at the same time. It is easy to get confused over this because sometimes mixed disturbances sort of mimics compensation, but if you keep your approach organized, you wouldn't miss it. We have two types of compensation. We have respiratory compensation and also we have metabolic compensation. Respiratory compensation is a fast process. It reaches to the max within seconds because all the body needs to do is increase or decrease ventilation. Obviously, the faster you breathe, the more CO2 you lose, which renders the environment less acidic. On the other hand, the slower you breathe, the more CO2 the body retains, which renders the environment more acidic and less alkaline. On the contrary, metabolic compensation is a slow process. It takes hours to days to fully develop. So early on, we have an acute metabolic compensation, and as time goes on, it becomes more chronic and the effect becomes more prominent. Now let's see how to interpret the situation. Just follow the order of events. First, identify the primary acid-base disturbance and then check for compensation. This way, you can easily identify the existence of any combined or mixed disturbances. The key is to keep your approach organized. For the first part, we want to identify the primary acid-base disturbance. We have 4 different types of primary acid-base disturbances, and to identify which one is which, first, look at the pH, and if it's less than 7.35, it's acidosis. If it's greater than 7.45, it's alkalosis. Next step is to look at pH and PCO2 directions. If they're going toward the same direction, we have metabolic condition, and if they are going toward the opposite directions, we have a respiratory condition. For example, pH is 7.31 and PCO2 is 33. pH is less than 7.35, so it's acidosis. The arrow is pointing down, and for PCO2, the normal range is 35 to 45. Here is 33, so this is also coming down. Arrows are going toward the same direction, and it's going to be a metabolic acidosis. Another example, let's say pH is 7.49 and PCO2 is 31. pH is greater than 7.45. Because it's going up, it's alkalosis. And the arrow is going up. PCO2 is less than its normal range, 35 to 45, so it's coming down. Arrows are going toward the opposite direction, and we have a respiratory alkalosis. We are done with the first part. Now for the second part, we need to check for compensation. We have 4 different types of primary acid-base disturbances, starting with metabolic acidosis. In metabolic acidosis, we have too little bicarbonate. Respiratory compensation is by decreasing PCO2 to bring the pH back up. As a result, patient starts hyperventilating to blow out more CO2. so the respiratory rate also goes up. Now, for the patient's bicarbonate amount, the expected CO2 is calculated by Winter's formula. 1.5 multiplied by bicarbonate amount plus 8 plus minus 2. This is the expected CO2 after compensation. And when you apply the numbers to this formula, then you compare the answer to the patient's PCO2 to see if the numbers match. Let's look at this example. Let's say pH is 7.10 and PCO2 is 34, bicarbonate is 18. Again, try to stay organized. First, identify the primary acid-base disturbance. pH is less than 7.35. It's acidosis. PCO2 is less than normal range for PCO2, which is 35 to 45. This is 34. So the arrows are coming down, same direction. We have a metabolic acidosis. Now let's check for compensation. The expected PCO2 for this amount of bicarbonate is 1.5 multiplied by 18 plus 8 plus minus 2. This is 27 plus 8 plus minus 2. The answer is 35 plus 2 is 37 minus 2 is 33. So the answer would be 33 to 37. This means if patient's PCO2 falls within this range, then the decrease that you see in PCO2 is due to compensation. Then the answer would be metabolic acidosis with respiratory compensation. Let's move on to metabolic alkalosis. In primary metabolic alkalosis, there is too much bicarbonate. Respiratory compensation is by increasing PCO2 to bring the pH back down. Patient's breathing pattern would become slow and shallow in an attempt to keep more CO2 in the body. So respiratory rate would decrease. In metabolic alkalosis, the expected PCO2 is calculated differently. Here you add 0.7 millimeter mercury to PCO2 for every 1 millimole per liter increase in bicarbonate. Now let's look at this example. Let's say pH is 7.48, PCO2 is 47, bicarbonate is 30. Again, let's identify the primary acid-base disturbance. pH is greater than 7.45, alkalosis, PCO2 is higher than normal level, same direction, metabolic alkalosis. Now let's check for compensation. Bicarbonate is 30 and normal level for bicarbonate is 22 to 26. Here it's 22 to 26. So 30 is 4 millimole per liter higher than normal upper limit for bicarbonate. For every 1 millimole per liter increase, you add 0.7 to PCO2. 4 multiplied by 0.7 is 2.8. This is the expected increase in PCO2 after compensation. Assuming PCO2 level was normal prior to these events, PCO2 level of 47 can be explained by compensation, meaning that PCO2 must have been somewhere around 44 or 44.2, then with 2.8 it became 47. Then the answer would be metabolic alkalosis with respiratory compensation. So now let's move on to respiratory alkalosis. Here, there's too little CO2. Metabolic compensation is by decreasing bicarbonate to bring the pH back down. The expected bicarbonate depends on timing. In acute phase, you see 2 millimole per liter decrease in bicarbonate for every 10 millimeter mercury decrease in PCO2. In chronic phase, you see 5 millimole per liter decrease in bicarbonate for every 10 millimeter mercury in PCO2. So you see more prominent compensatory changes as the time goes on. Again, let's look at an example. Let's say pH is 7.49, PCO2 is 30, and bicarbonate is 17. Again, what is the primary acid-base disturbance? pH is greater than 7.45, alkalosis, arrow going up, PCO2 less than normal level, coming down, opposite directions. It's respiratory alkalosis. Now let's check for compensation. Normal level for PCO2 is 35 to 45. Try to keep it simple, so let's go with the average 40. 40 reached to 30, we have minus 10. We have 10 millimeter mercury decrease. Normal level for bicarbonate is 22 to 26, and 17 is 5 millimole per liter less than the normal lower limit. This much decrease in bicarbonate is in accordance with chronic metabolic compensation, because as you see, in acute we only have 2 millimole per liter decrease. Here we have 5, so you can say that more time has passed, and the answer would be respiratory alkalosis with chronic metabolic compensation. Now let's move on to respiratory acidosis. In primary respiratory acidosis, there's too much CO2, so PCO2 is high. Metabolic compensation is by increasing bicarbonate to bring pH back up. Here, the expected bicarbonate again depends on timing. In acute phase, you expect to see 1 millimole per liter increase in bicarbonate, and in chronic phase, you expect to see 3.5 millimole per liter increase in bicarbonate for every 10 millimeter mercury increase in PCO2. Let's look at an example. pH is 7.11, PCO2 is 50, and bicarbonate is 27. Primary disturbance is, this is coming down, this is going up, opposite directions, respiratory acidosis. Now let's check for compensation. PCO2 is 50. Again, if we assume that PCO2 was 40 prior to these events, then we have 10 millimeter mercury increase in PCO2. Now let's check bicarbonate. The normal upper limit for bicarbonate was 26. Here it's 27. We have 1 millimole per liter increase, which is more in accordance with an acute metabolic compensation. And the answer would be respiratory acidosis with acute metabolic compensatory changes. And also notice that in compensation, bicarbonate and PCO2 always move toward the same direction. When one goes up or down, the other one does the same. Every time you check for compensation, compare the expected compensatory value to the patient's level. If the levels are way off from one another, in an otherwise healthy individual who does not have respiratory or kidney problem, suspect it could be a mixed disturbance. And again, correction and overcorrection of pH always means mixed disturbance. Now this brings us to the end of the video. Thanks for watching.